Welcome to the IFRS summary videos. These are summaries of Zoom lectures that were arranged by IFRS during the lockdown. Please have a look at the original lecture because they have more information and also videos which will show you how to do things. Today we're going to talk about gasless appendicectomies. Appendicectomy is one of the most common surgeries which is performed all over the world. In fact, the first successful appendicectomy was carried out in 1735, which is fairly long ago. And it is only in 1880, Robert Lawson Tate diagnosed appendicitis and proposed appendicectomy as a treatment option. And the first scientific paper was published about 6 years following this. However, it was in 1893, Charles McBurney was the one who popularized appendicectomy. And most of us remember McBurney's incision or the point. And it was a gynecologist called Kurt Sem who did the laparoscopic appendicectomy in 1981. Regarding appendicectomies, it's probably the most common emergency surgery which is carried out all over the world, with a lifetime incidence of about 8%. And there are some interesting incidences where in 1961, Leonid Rogov, a Russian doctor, who, when he was in Antarctica, carried out appendicectomy on himself. And the open appendicectomies remain the gold standard for more than 100 years. So much so that when there is a McBurney's incision, people assume that appendicectomies are carried out. And as we said, Kurt Sem was the one who started laparoscopy appendicectomies. And it became popular in the 90s. And by the year 2000, almost half the appendicectomies in the Western world were carried out with laparoscopic surgery. However, they found a slightly higher incidence of postoperative abscess and other things with the laparoscopic appendicectomy. But then obviously the pain was less, the recovery was faster, and wound infection was much less with the laparoscopic appendicectomies. And the outcome was obviously better in children and in the elderly. These two group of patients, the clinical diagnosis is a little difficult because appendicectomy is classically diagnosed by clinical methods. And the signs are not very obvious both in the children and in the elderly. So diagnostic laparoscopic before appendicectomy became a part of the procedure. And the single incision appendicectomies with the large umbilical port started in 1992, almost as soon as laparoscopic appendicectomies were started. And one other finding was that almost a third of normal looking appendix was in fact inflamed when examined histopathologically. And so there was a tendency to remove the appendix when any patient was posted for appendicectomy, especially if they're doing open surgery. And many people shifted to laparoscopic surgeries because the pain was far less and the recovery was faster. And single incisions became popular because it leaves almost invisible scar because the incision is in the umbilicus, which is a natural scar. But then the problem with the single incision surgeries is that it takes much longer time. And even though the various scores in very large meta-analysis, like the duration of stay, pain, and need for analysis, etc., was almost similar to conventional laparoscopic surgeries. Then people even tried nodes and natural orifice transumbilical endoscopic surgeries. But of course, all these things are much more expensive and require more skill and take a longer time to perform. And the problem with the SILS we discussed earlier is that because the ports are very close to each other, there is clashing of instruments. So, and also the lack of maneuverability, and the exposure again is poor. So all these things make what is supposed to be a simple task very, very difficult. But then there are methods which make it a little more easier, especially for rural areas. There's a doctor called Dr. Elbert in Northeast India who devised this glove port. So you do a single incision, and the fingers of the gloves are used for the various ports. But again, here the problem is that even though it is very nice, any small injury to the glove with the instrument which are often sharp, then the whole system collapses and we need to insert the port again. It takes time and you need to be an expert to do it. And it is here the gasless surgeries or the single incision gasless surgeries have a huge advantage. Here, because there is no gas, it can be done with a much smaller incision. And it is much more easier because you can use regular open instruments for holding and so on. But one of the things you need to remember is that with gasless, it's not the gas which pushes the intestines away. So you need to really tilt the table, especially either the head down or the lateral tilt, so that intestines fall away from the appendix. And if you have head down, you need to make sure that you have a shoulder brace which prevents a patient from slipping away. And as discussed earlier, the method to carry out like this: first fix the lift apparatus almost 6 inches from the place where you want the lift to be there, and then make an incision in the umbilicus, cutting through the lower half of the umbilicus, and then making a transverse incision in the rectus. And we use a special H-shaped retractor. And again, we make sure that you pass the finger and sweep around to make sure there is no bowel or additions. And again, the same thing you need to repeat while fixing the lift apparatus. And then you have a look at the appendix. You can use whatever means you have, either monopolar or bipolar or vessel sealing. All you need to do is hold the appendix up and divide the mesentery near the base. And you can tie the appendix. Here again, a variety of methods can be used. If you're not very familiar with the laparoscopic tying, it's easy to use a loop. And we also, probably in the main lecture, describe how we make a low-cost endo loop using a pusher and proline suture. And if there's an abscess, you just drain the abscess. And the end result is really good because it's a single incision and the hardly visible scar once the incision heals well. And obviously, there are no complications which are associated with conventional laparoscopic surgeries or the physiological changes which are there. So this is how we make this Roders or modified fisherman's knot to use along with the pusher that we have for DJ stenting to make a low-cost endo loop. And in the simulator, one way of practicing doing appendicectomies is use this low-cost pusher and a stuffed glove, which looks almost like an appendix. You can hold the appendix and keep practicing tying various knots. The knotting can either be extracorporeal or intracorporeal. Extracorporeal, you need to learn how to use the pusher. And these are some, the original lecture has videos of how you can do single incision knotting, which takes a little practice, and that is why you need to first practice and do it. Summarizing, the gasless laparoscopic surgeries has the advantage that it is possible to do them under spinal anesthesia, and you don't need the logistics of the various gases, both for anesthesia and for surgery. And these skills can very easily be learned in a small trainer box. And it's single incision surgeries are much more easier with the gasless surgeries compared to traditional surgery. So it makes it the ideal procedure for appendicitis or for doing appendectomies. Thank you.